on our Auricle 90 days foundational course live class for university exams. I'm Dr. Ankit, faculty of anatomy, and today we are going to discuss or continue our discussion of the surface anatomy, which we did in the previous session as well, right? In the previous session, we talked about the upper limb. Now we'll talk of the lower limb. Fair enough. So these are the first year surface anatomy part 2. Part 1 has been done already. It is going to benefit for our university exams as well as for our NEET PG or next PG exams, which you will be seeing in your career later on. You can use this code for discounts on subscription. These are all the sort of questions which are asked. You can take a screenshot of them as well, where you have long essay questions, you have short essay questions, and you have also short answer questions, right? Okay, now why to choose Auricle? There are various benefits. They'll just go through the slides and they'll repeat again in the when we'll end the session. So we have recorded live classes, we have practical sessions, we have exam modules, and we also have the hard copy book set. So recorded live, practicals also, hard copy notes, beautifully crafted, and rapid exam modules as well. So here are the benefits of recorded classes, the live classes, the exam module. Also have a special doubt clearing session here as well. Plus we have this hard copy notes, and you can have this QBank as well with our practical sessions. These are the various subscription plans, which you can see, which range from period of 3 months to 6 months to 12 months to they may go up till 4 years. That is covering entire MBBS curriculum over here. Okay, and different you have this price tag over here. You can do this, and you can use the code Dr. Ankit 20 to get some discounts for it. Fair enough. Let's come to a topic of discussion, and the topic of discussion for the current session is our surface anatomy. So let us jump straight away to the surface anatomy part. So here is a surface anatomy part over here, and we'll be beginning with the lower limb today. So yesterday we did the upper limb, and I'm sure for those who have gone through the videos, they may have tested few of the structures on their own body or on your friends or roommates. So today we'll be doing the lower limb. Okay. So after upper limb, we do the lower limb normally. Why? Because most of the things are very common in both upper limb and lower limb anatomical wise. Therefore, for surface anatomy also we can go with it. So let's start the lower limb, and how to start with it. Start with the main artery over here, which is our femoral artery. Like if you guys remember that we started the upper limb with which artery? With the axillary artery. Here we'll start with the femoral artery. Okay, it is a main vessel supplying the entire lower limb, so it becomes very important. And let me tell you, it is also easily palpated. Okay, I'll tell you its clinical relevance also. So what are the points over here? Number 1 point, as you can see, is the mid-inguinal point. So mid-inguinal point is what? It is a region between your inguinal areas, or the two points which form the inguinal ligament. So what are those? One particular landmark over here, which we can easily feel, is anterior superior iliac spine. ASIS is anterior superior iliac spine. And second point in the middle, anteriorly, we have this pubic symphysis. So these two are the bony landmarks, ASIS and pubic symphysis, which can be easily palpated no matter how obese a patient is. So you can easily palpate them. Okay. Once you palpate these two, you know roughly that how much is the total length of it. It is around 8 to 10 centimeter. And you then take roughly around their midpoint over here. You press your finger over there. And once you start to press your finger, then you feel then you start palpate, and then you feel the pulsations of this artery, that is the femoral artery. Okay. The one condition over here is that if you are doing this, if you are trying to palpate the femoral artery, the one thing is the patient should be entirely lying supine. What do I mean? Some students do the mistake that suppose there's a patient who's lying supine, head, neck, the trunk, right? And these are the lower limbs. Okay, these are the two lower limbs over here. So then they start to palpate over here, then it is okay, it is fine. You will easily palpate the femoral artery. Other scenario could be when the person is lying supine, the person might, flex the hip area over here. So in that cases, once you start to feel for the femoral artery, it becomes a bit difficult. So therefore, you have to make the patient entirely supine with the lower limb also parallel to the surface. Then only you can easily palpate the femoral artery. So that is one point. Point number 1. So it starts from here. And let me tell you, before it, the artery is not coming all of a sudden from anywhere. No, there's an aorta which is coming out from the heart. Then it gives out different branches, and finally we have a femoral artery. So before femoral artery, or femoral artery is a continuation of, remember, external iliac artery. So it's the same vessel, but in the abdomen we call it as an external iliac artery. So external iliac artery will continue down as femoral artery. Okay, so point number 1 is, I hope is clear. And that's very important to palpate. I will tell you it's another clinical relevance. Number 2 point is adductor tubercle. So what is adductor tubercle over here? So again, you will easily feel it on the medial side of the knee area. You feel this adductor tubercle, and then you take these 2 points. One is this midinguinal and one is adductor tubercle. You join the above. The upper 2/3 of the line represent the femoral artery. So suppose this entire length is around, say, this to this, say it is around 45 centimeter. So per 2/3. So 2/3 of 45 is how much? It is around 30 centimeters. So 30 centimeter of this area, 30 centimeter of this point, it will tell you the location of the femoral artery. Now comes, okay, fine, we know roughly where does the femoral artery lies. So can you tell its clinical relevance, applied importance, which we can see, or which we will see in our practical life, or which can come in the questions? Yes, there are. One is butcher's injury. What is butcher's injury? See, if you go to any places who sell the non-veg shops, they are sitting with the alti-palti posture, and they have that wooden block in which they keep the non-veg material, the meat, and they slash it with their sharpened weapon, whatever it is. And that weapon, once they are striking it over that meat part, is very close to their thigh, middle part of thigh. Suppose by chance that sharpened weapon, at instead of striking the meat, it strike their medial thigh, then this is the area where it will normally strike. Okay, and it is so sharpened, so heavy, that it can easily damage quite a substantial area of the tissue of the lower limb. So if that sort of person is coming to you, you know, okay, that femoral artery is quite at risk, because if artery is damaged, then obviously there will be severe loss of blood at a very high speed. And if the entire artery is damaged, let me tell you, it will be very hard to save the patient. Why? Because obviously patient is going to take at least 15-20 minutes or half an hour to reach the hospital or the wherever the facility is there. And that much of time, obviously, the blood is going to come out, and due to the loss of blood, it will be very hard to save the patient. That is one thing. So you should know femoral artery over here. Second applied importance, which is actually, these are the special cases. So any injury over here, you should be well aware. The second applied importance is over here. Let me tell you that just medial to femoral artery, over here, you have one more structure. What is the name of that structure? That structure is your femoral vein. What is that? Femoral vein. It is where it is just medial to the femoral artery, not lateral, just medial. So what is the use of it? Previous session we discussed about a vein in the upper limb, that was a median cubital vein, if you remember. Okay, median cubital vein. Now see, there are various clinical cases. Suppose a patient is a cancer patient who has undergone the cancer therapy. So in patients who have undergone chemotherapies, okay, so patient, normally there are a lot of patients nowadays who have undergone chemotherapy. So patient undergoing chemotherapy, or he is a IV drug abuser. Okay, nowadays there's a lot of substance abuse also, which is quite common in India also. In a recent study, it is around, say, it is said to be around that 15 to 19% of the college going students are under some substance abuses, which is not good news. But yeah, there are a lot of cases. So IV drug abuser, these sort of patients, already their veins have been utilized quite a number of times. So in those patients, these sort of veins, median cubital vein or any other vein, it will be very hard for you to take the blood from those veins. So in those cases, what can be done? In those cases, you can take the blood out from the femoral vein, because it is slightly deeper located vein. And very rarely you will see IV drug abuser giving himself the drugs through the femoral vein. So now how to locate the femoral vein? Simply you put your finger over the femoral artery. How to put a finger over the femoral artery? Just midinguinal point, and putting a finger over here, you will definitely, palpate the femoral artery due to its pulsations. Now you just go needle to it. 90-degree your needle will go, and your needle will be directly inside the femoral vein, and then you can take the venous blood out of it. That is known as your femoral tap. So that is given a special word known as femoral tap. So if you know the surface marking of femoral artery, it will help you in so many things, as I told you 3-4 examples over here. So that is a very important part which you should know. Coming back, mid-inguinal point number 1, second point adductor tubercle. Join them hypothetically line, and upper 2/3 will be the anterior, or you can say the location of the femoral artery. But also some of you might think that's after, where does the femoral artery goes? After you're saying upper 2/3, what about the lower part? How will it go lower down? Actually, what happens is that from here, from this point, the femoral artery goes backward, because we have to bend our knees also. Now imagine the femoral artery is running anteriorly in the knee. If you bend the knee, what will happen to the femoral artery? It will obviously be stretched. Therefore, the femoral artery goes behind into the popliteal fossa, and in this popliteal fossa area, we call it as a popliteal artery. So popliteal artery is nothing but a femoral artery, but a continuation of femoral artery in the popliteal fossa. Like external iliac artery gave femoral artery, and femoral artery became popliteal artery. Simple as that. I hope the point is clear, right? Okay, so let us move from the femoral artery. Now let us see the popliteal artery, which I was just discussing. So you can see this image is a posterior image. The upper image which you saw over here, this image, if you focus, it is the anterior view. This image over here is a posterior view to show you the popliteal artery. So again, to start with, obviously it will start from where the femoral artery ended, and therefore at the junction of midline lower third of the thigh, 2.5 centimeter to the midline. Fair enough. So that is point number 1. Point number 2 is the midline of the back of the knee. So back of the knee, right at the midline, you will be finding the popliteal artery. And as you go below, back of the leg at the level of tibial tuberosity. What is tibial tuberosity? It's a landmark in the tibia bone. In the tibia bone, we have a tibial tuberosity. How to identify it? Let me tell you that also. If we see an anterior image over here, okay, let us see an anterior image. See over here. This area, if I may slightly try to zoom it to show you the tibial tuberosity. Okay. So this area over here, this area is the tibial tuberosity. I'm writing TT. Why is there a tuberosity? See, question should be coming into your mind. What happens over here? See, all the muscles lying in the anterior thigh, the quadriceps, the bulky muscles, they all form a tendon, and then that tendon will insert into the tibial tuberosity. Remember the patella bone over here, right? So if you feel the patella bone, just below it, you will feel a very strong, hard tendon that is inserting into tibial tuberosity. So that is the level of tibial tuberosity. So now what they're saying for the popliteal artery case, that okay, the third point over here is at the level of tibial tuberosity. So till from here to here, this is the level of tibial tuberosity. So from the beginning over here till here, we have the popliteal artery. Mind you, it is the same as femoral artery, only the names have changed. Like for example, let me give you one more example, which I normally give. India is a country of so many states. Suppose you have 3 states over here, A, B, and C. Let us just hypothetically name A, B, and C. And there's a river flowing from A, B, and C. Okay. Or let us say A, B, and C, forget the states, there are 3 countries. Small countries are there, 3 countries, A, B, and C. That will be a better example. So what will normally happen is, in country A, this river name will be different. In country B, the same river name will be different. In country number C, this river is same, but the names differ. Obviously, country-wise, they give the name according to their local language, or whatever their native language is. Similarly, this femoral artery is the same. As you go into the popliteal fossa, we call it as popliteal artery. So now it is lying at the posterior aspect. Okay, and remember, not nowadays, but few years back, for example, not few, but let me say 50, 100 years back, when the horse riding was quite a common sport, quite a common mode of living in day-to-day life of individuals throughout the world, this popliteal artery over here was exposed, or was exposed to a lot of physical stress and physical injury. Why? Because sitting on a horses, and they wear the high boots, and you have to obviously bend the knee. The horse, you have to, the horse is running, and obviously you're also moving up and down. Then that boots strike the popliteal fossa, always and always putting a physical stress on the popliteal artery, such that the normal anatomy of the popliteal artery and the popliteal vein, they might develop aneurysms. The popliteal vein might develop some clots and all. So those things were also quite common at that time. Nowadays, obviously, we know the horse riding is present there, but not that much prevalent what it used to be. So this is the location of popliteal artery, do remember. Okay. Can we palpate it? Should be your next question. Yes, you can. Yes, you can definitely palpate it. But remember, in this popliteal fossa, there are other structures also, like popliteal vein is also there. There are different nerves like tibial nerve is also there, and there's popliteal artery. Now, out of all these structures, understand that this popliteal artery, which we are talking right now, is the deepest lying structure in the popliteal fossa. Deepest lying structure. So while palpating, what you have to do? You have to give a deeper palpation. Okay, it is not as easy as palpating the radial artery or not as easy as palpating your femoral artery. You have to give a deep push. So it is not very easily palpated, but yeah, with practice, you can easily palpate it. Okay, popliteal artery is palpable, though not easily as the other arteries which I just mentioned. No, popliteal artery is still the your tibial tuberosity. What after that? What after that? After that, see, this popliteal artery is going to divide into two arteries, which one name you can see, one is posterior tibial, and obviously other one will be the anterior artery. So needless to say, which one will be where? One will be lying posteriorly, one will be lying anteriorly in the leg region. So they are known as anterior and posterior artery. Let us see the posterior artery. It is also very important. So you can see the image over here. This is where the point number 3 was for the popliteal artery at the level of tibial tuberosity. So on the midline of the back of the leg at the level of tibial tuberosity is point number 1. Okay. Midway between medial malleolus and tendocalcaneus. Okay. So what is that? If you see your own foot, the most strong tendon, the most prominent tendon at the back of your foot is this tendocalcaneus. Achilles tendon, also known as what? We all know it is also known as Achilles tendon. It became quite famous once that movie came, no? That Achilles heel. That movie came. I'm not remembering the name of that movie, but yeah, quite a few years back, it was an Hollywood movie. It came. I'm still not remembering the name. So whatever is the name. So Achilles heel is famous for it. And this is a tendocalcaneus. It's a tendon having for the muscles gastrocnemius and soleus. So these two bulk muscles, they form a tendon known as Achilles tendon, which inserts into the calcaneus bone. So we call it as tendocalcaneus. Fair enough. Apart from this, if you look at your own ankle, then on both the sides of the ankle, you see a bony projections. On both sides of the ankle, you feel the small elevation. These are the bony projections. On the medial side, we call them as medial malleolus. On the lateral side, we call it as lateral malleolus. Simple as that. This will be coming from which bone? Medial bone of the leg is tibia. The lateral bone of the leg is fibula. Fair enough. So these are all the sides. Now the tendon was coming over here, the very, very, very tough tendon, tendocalcaneus or Achilles tendon. Now right between them, this is the location of what? Posterior tibial artery. Posterior tibial artery. Now the point comes, sir, where can we palpate it? Can we palpate it? The answer is again yes. Obviously in the leg region. You can't palpate it over here at the upper part of the posterior tibial artery because it is obviously covered by all your calf muscles. Calf muscles are quite big muscles. So you can't palpate it over here. It is lying deep to these muscles. But over here at the lower portion, you can easily palpate the posterior tibial artery. And I would urge all of you to please palpate the posterior tibial artery. Between your tendocalcaneus and your medial malleolus, this is tendocalcaneus, you can easily palpate posterior tibial artery. Okay, I hope if some of you have started to palpate, then you might be successful. It is very, very easy. Now question is, okay, fine, sir, we have palpated. But sir, okay, palpate, what can we think of any other clinical use? Is there any other clinical use apart from, okay, palpating, we are palpating the artery? Fair enough. What is the clinical or applied importance? Is there any other? Yes, there is one thing. What? See, in the lower limb, the blood vessel, the artery, as we saw, femoral artery in the front, then we have the popliteal artery, then we have this anterior posterior tibial artery. Sometimes patients come with, this changes in the skin of the foot, right? Pain during walking. They start to walk after 100, 200 meters, they have pain because some atherosclerosis, some cholesterol starts to deposit in arteries. Now see what happens is, if you can easily palpate the posterior tibial artery in a patient and you can easily palpate it and it is giving a normal pulsation, you know that okay, the femoral and the popliteal artery and the posterior artery are okay, because still here the blood is coming at a fairly good speed and quality and quantity. But if you can't palpate the posterior artery, you know that or the pulsations have become very low. You know that the blood at which the normal it should be coming, it is coming at a much smaller pace or much smaller volume. So this will give you an idea without undergoing any investigation. Okay, seems to be some issue with the vessel. So now you can plan an investigation like Doppler study and all that you can plan out. So by simple examination, that is why experience is needed. We need you guys to go to the clinics once you reach that stage in your college and you see the patients. You do the examination more and more. The more and more you do the examinations, the more patients you see, only then the confidence will come. Okay, so this is the relevance of posterior artery where you can easily palpate it also. Now let's see the anterior tibial artery, right? First we've seen the posterior and anterior. See, anterior and posterior tibial artery both are coming from where? Both are coming from the popliteal artery. So the beginning of both these will be the same, right? Because where the popliteal artery ended. The second point is the midway between the two malleoli, but where anteriorly. It is the anterior tibial artery, so anteriorly. So this is the medial malleolus. If you can easily see, this is the lateral malleolus. Between these two, this is where the anterior tibial artery will be lying. And from here, let me tell you, it continues into the dorsum of the foot. It continues into the dorsum of the foot, and this artery over here will be known as dorsalis pedis artery. Okay. Now, some of you might be wondering, sir, in medical science, sir, we have taken the admission, but sir, there are so many names. Names are self-explanatory. Dorsalis pedis. Dorsalis. Okay, now if you look at the hand, this is the palm of the hand. This is the dorsum of the hand. Similarly, if you look at your own foot, then the lower part of the foot is the plantar aspect of the foot. Okay, imagine the whole foot. The lower part is the plantar aspect, and the upper part is the dorsal aspect of the foot, where the skin is very loose. So this artery is running where? This artery is running in the upper part of the foot. So we call it as dorsalis. Pedis itself means foot. So on the dorsum of the foot, dorsalis pedis, we have an artery. So we call it as dorsalis pedis artery. Now tell me, is that very difficult? The name itself is telling us the location. Again, can it be palpated? The answer is a big yes. You should practice to palpate this dorsalis pedis artery. Also, where to palpate? Again, between the two malleoli, palpate it over here, or slightly move your finger a couple of inches in front, then you can palpate this artery over here. Now, again, the same clinical scenario, because whenever I try to teach anything, there's always a clinical evidence, because else its use is very limited. So now tell me, if you are palpating the dorsalis pedis artery, if you are palpating the posterior tibial artery, so if anteriorly this artery can be palpated, if posteriorly posterior tibial artery is easily palpated, tell me, do you need to palpate popliteal artery? If the blood is reaching at the terminal parts easily, and you are easily palpating, there is no need to even palpate popliteal artery. You will yourself be sure, okay, if these both arteries are easily palpable, obviously popliteal artery will be fine. Then there's no need to go for a Doppler study for arteries. Because once you're writing any investigation, it should be justified, no? Nowadays, you might be hearing that, okay, patients do complain that, okay, doctors are doing this investigation of no use and all that. But let me tell you, these are important. And if the investigations are coming normal, don't be in that state of mind that, okay, why I ask for these investigations? But yeah, your investigation should be justified. That on examination, the posterior tibial artery and the dorsalis pedis were not palpable. Advise Doppler study of the lower limb arteries. Okay, and then you might find some atherosclerosis, some blockage in the artery. Okay, so remember that clinical importance as well. So anterior tibial artery, and here is the dorsalis pedis, which I just told you. So it is from here to here. So midway between the two malleoli and proximal end of first intermetatarsal space till here. So here is the area where you can easily palpate the dorsalis pedis artery. Okay, so practice palpating these arteries. Because see, every individual, you might encounter some changes here and there. Some changes. Not everybody is exactly the mirror image. No, the whole world of 8 billion are not clones, right? So everybody there are minor changes. So keep practicing. Okay, so this artery, then coming to palpation of arterial pulse. As we discussed, femoral pulse inferior to the inguinal ligament at mid-inguinal point. I hope this point is clear. I already told you. Popliteal pulse popliteal pulse deep in the popliteal fossa, medial to the midline. So deep, it is always deep over here. So this is where the popliteal artery is being palpated. This is where the femoral, and below is the popliteal artery being palpated. Nowadays, let me tell you, images like this come in your PG exams. Simply images like this. And they'll give you options, which of the following vessel is being palpated in this particular examination. And the image is over there. Recently, as I'm telling you, you look for the previous year questions, posterior tibial artery has been asked. Okay, so this is popliteal artery. And as you go below, posterior tibial, this sort of image was there. This sort of image was there in one of the exams. Okay, posterior inferior to the middle malleolus, and then you have the dorsalis pedis pulse over the tarsal bones between these tendons. Fine. So it is palpated over here between two tendons. Now that can also be a theory question. I am not telling you the name of tendons again because that will come later on. But obviously, one tendon is going to the great toe, so we call it as extensor hallucis longus. Other tendons are going to the great, so we call it as EDL. Just you ask the patient to extend the toes, you will see these tendons. Forget the patient, do it on yourself only. You extend your toes, you will see these tendons. And between these tendons, okay, you know where you have to place your finger to palpate the dorsalis pedis artery. This is how you can start to practice them. Okay, now there was a arteries, which is very, very important. So in the beginning, now coming to the veins. Now, let me tell you, before we begin this, in upper limb also we studied veins. If you remember, then we studied about cephalic vein, right? Sort of veins, median cubital vein, applied importance. But the anatomy of the veins, particularly, are more important in case of lower limb than upper limb. I'm sure most of you must have heard of the word or the disease varicose veins, right? Varicose veins, very, very common. The problem over here is that the blood in the veins of the lower limb, have to go against the gravity. That is the issue. So if there is any anatomical problem or there any pathology in the venous anatomy, then the blood which is going against the gravity obviously will be difficult for it to go. Then starts the accumulation of blood in the superficial veins. That is what is known as varicose veins. And therefore, you should know where the veins are actually lying, mainly superficial veins. If you remember, in the upper limb also, we mainly dealt with the superficial veins, median cubital, cephalic, and all that. Similarly, in the lower limb also. In the lower limb, actually, they are more important. Okay, varicose vein is one of the most commonly disease. So in professions in which the people have to spend on a daily basis for prolonged number of hours, like a traffic policeman or a surgeon who is doing long surgeries, or any profession where they stand for long hours, this varicose vein may easily develop. Okay, so first vein over here is what? It is a great saphenous vein. Great saphenous vein. Other vein also there, small saphenous vein is also there. So great saphenous vein, let me tell you from before itself, it is a superficial vein. It is a superficial vein. Second important point about this vein is it is the longest cutaneous vein. When we say cutaneous, we mean superficial vein. Longest cutaneous or superficial vein in the entire body. Because it starts right from the part of the foot, as you can see, point number 1, and it goes up till point number 5. That is up till the inguinal region, where it will drain into the femoral vein. So the entire length of lower limb is the entire length of great saphenous vein, and very prone to develop varicose veins. So let us see the points. Point number 1, 2, 3, 4, 5 are written over here. Let us easily see. Point number 1 is where the vein will start. On the dorsum of the foot at the medial end of the dorsal venous arch. Because this image, if you see, we are looking at a medial aspect of right lower limb. Medial aspect. So we are looking at a medial aspect. So on the dorsum of the foot at the medial end of the dorsal venous arch is point number 1. Okay, just a second. Okay, second point over here is anterior surface of medial malleolus. I'll tell you one very, very, very life-saving applied importance over here as well. Just in front of medial malleolus. Where was the posterior tibial artery? If suppose this is a side view, then okay, let me show you here only. This was the location of posterior tibial artery, if I may label it as posterior tibial artery. So posterior tibial artery was behind medial malleolus. It was an artery. The great saphenous vein is just in front of medial malleolus. You can't feel the pulsation, but you can easily palpate because it is a bony part. Medial malleolus is a bony part. And if you take few seconds and look here at your own foot in front of medial malleolus and try to palpate, you will easily feel the great saphenous vein. So that is point number 2. Point number 3, I will come to its applied importance also. That is a life-saving. Point number 3 is on medial border of tibia at the junction of upper 2/3 and lower 1/3. So for this point number 3, again medial side. Point number 4 at the adductor tubercle. Remember that femoral artery. And point number 5 at the saphenous opening. It is known as saphenous opening because the great saphenous vein opens over here, 4 centimeter below and 4 centimeter later to the pubic tubercle. So what is this whole pubic tubercle thing? See, what we are discussing over here is, let me use this color. This was pubic symphysis, if we remember. Just over here, we have the 2 pubic tubercles. 4 centimeter below, 4 centimeter later. This is the point of saphenous opening. This is point number 5. So remember these points. Now coming to what I was saying, okay, let me tell you this applied importance in front of medial malleolus. See, what happens is, suppose you are again in an emergency, and these situations will come later on. And I hope that if you are listening carefully, at that time, when the sort of patients will come, the clinical case scenario which I'm going to tell you, these words you may recall and it may help you and the patient. So in case of emergency or casualty, when a patient comes with a bleeding and all, a patient is in shock, the BP is falling, BP is say 80/60, 80/50, 90/55, whatever, the BP is falling, you know the patient is going into shock. There's loss of fluid in the blood vessel, or the blood loss has happened. The first thing that you need to do is you need to do a IV sample line over here. You need to put some, insert some fluid inside the patients slowly. Those normal saline or ringal lactate solution. Now, when the person is going into shock, when the blood is very less in the circulatory system, normally the superficial veins, they start to collapse. They start to do what? They start to collapse because there is very less blood. The property of veins is they are the reservoir of blood, but now already the blood is going so less, so the veins start to collapse. Now you're feeling for the veins here and there, and you start inserting the IV lines and unable to find the veins. And femoral vein, you can't insert the IV line over there. Why? Because the moment the patient will fold the lower limb, that vein will compress, or whatever IV line you have placed, that pipe will compress. In those sort of situations, when you are feeling helpless, what to do? Then either you can go for the central venous line over here for the internal jugular vein, but that is not easy. In that case, if you know that in front of the medial malleolus, because there is not any big artery or nerve over there, so you can easily do a small incision in front of the medial malleolus and open that area. You will see the vein and you insert your IV line over there, both the sides, and the fluid is inside the blood vessel of the patient. The heart will again begin to beat, the BP might improve, and you might save the patient. So do remember, just in front of medial malleolus, there is great saphenous vein. Varicose vein, I already told you. So if you are seeing a tortuous vein, a patient comes to you with a tortuous vein over here in the medial side, you know, okay, it is the great saphenous vein which is being problematic over here. Okay, so to recap what we have just learned, the longest cutaneous or superficial vein in the body, very important because blood is going anti-gravity from bottom up. Okay, if we are sitting and standing and walking, all the time it is going bottom up. These are the points. Number 2 point is most important, and then number 5 point is also important. Why? Because this is where you have to do some clinical examination for testing the varicose veins and all. That will be dealt in surgery later on. Okay, so I hope this is clear. Next, come to the femoral veins. Femoral vein is a deeper vein. It is not a superficial vein. It is a deep lying vein. You won't see it on the surface. It is a deeper lying vein. Okay, femoral vein. So it is similar to the femoral artery, except, so femoral artery, if you remember, mid-inguinal point, adductor tubercle, upper 2/3, and then going behind. It is same as femoral artery, except it is one, as I told you what. If you remember, guys, as I told in the beginning, femoral artery was over here. I told you just medial to it, you will find the femoral vein, and that is what it is written over here, 1 centimeter medial to mid-inguinal point. So if you want to do a femoral tap, as I told you, was just to take 5 ml or 10 ml of venous blood or sending some samples, any sodium, potassium, LFT, KFT, whatever it is. That is not you're putting, no, you're not putting an IV line over there. So it is just medial to that part. And as you go below, it is lateral to the adductor tubercle. Okay, join the above line, upper 2/3, same as that. So remember, it is just medial to the femoral artery at the mid-inguinal point. Clinical importance is that. And that is what will be asked from you. Now, saphenous opening, if you remember, 4 centimeter below and lateral to the pubic tubercle. Let us see. So this is a pubic tubercle. Now, let me tell you a bit of anatomy also over here. See, what happens is, if we enlarge this area, see, these are the two hip bones over here, and they will meet. And this area is what is known as pubic symphysis. And when we say symphysis, if you have seen our joint lecture, then you will recall that symphysis is a secondary cartilaginous joint. Secondary cartilaginous joint. But now from the pubic symphysis, what happens is you have a bony line over here, a bony projection again over here, and that is known as pubic crest. These are the terminologies which we need to know a bit. And then where the pubic crest ends laterally, this point is known as what? This point is known as pubic tubercle. Pubic tubercle. That is pubic tubercle. So there are 2-3 terminologies over here. Don't mix them up. One is pubic symphysis at the midline, that is a secondary cartilaginous. One is this pubic crest, one is the pubic tubercle. So where was the saphenous opening? It lies 4 centimeter below and 4 centimeter lateral to the pubic tubercle. So it can be palpated, guys. Do palpate it on your own. Palpate the pubic symphysis. Try to palpate the pubic tubercle. And it is about 2 points. This opening is about 2.5 centimeter long and 2 centimeter broad, somewhat like this. Okay. Whether it's long, it's directed downward and laterally fine. Now, this is important. Why saphenous opening is important? I told you when we are doing examinations for varicose veins. Suppose a patient has varicose vein and you want to demonstrate clinically. So you just compress over this saphenous opening. Now, what you're doing, you're just blocking the entire drainage of the great saphenous vein. Again, the varicose vein, obviously, and you start the patient to stand, then varicose vein will increase. You can demonstrate the varicose vein in patients by blocking the saphenous opening. And this you can easily block only when you know where the opening lies. So to know where at 4 centimeter below and lateral, you should know where is pubic tubercle. To know pubic tubercle, you should know pubic symphysis. And to know all of this, you need a basic anatomy, right? So this is how you can help with this. Saphenous opening. Now coming to the nerves. Femoral nerve. Okay. Femoral nerve, see, remember, this is the inguinal region. Let me tell you this brief idea over here. This is your ASIS, right? And this is your pubic tubercle. I'm writing PT over here. And between these two structures lies a ligament that is known as inguinal ligament. What is this? Inguinal ligament. It is actually a sort of tendon of a muscle. So in this region of inguinal, if you go from lateral to medial, you have nerve, artery, vein. Remember NAV over here. Again, I'm writing nerve, artery, vein. Where to where? Lateral to medial. So you already know artery and vein line medial, and more lateral to the artery is the femoral nerve. Simple as that. So 1.2 centimeter lateral to mid-inguinal point. So at the mid-inguinal point was the artery, and just half inch lateral to it, you will have this femoral nerve. And medial to the artery, what we had a femoral vein. Do remember? NAV, nerve, artery, vein, where lateral to medial side. So on the other side, it will be like this, N, A, and V. Remember this, right? 2.5 is 1 inch vertically below the first point. So it is 1 inch below also. Then you might want to then say where the nerve went. See, nerve does not go anywhere. What happens is, as soon as the femoral nerve goes down, it rapidly divides into anterior posterior divisions, and then the lot of branches supplying the muscle and the skin and fascia over there. This is femoral nerve for you. Okay, do remember that also. Sciatic nerve, I am sure most of you must have heard of a term sciatica, pain in the buttock region and the lower limb behind. Sciatica, must have heard about it. That is actually compression of sciatic nerve. And another, yesterday we discussed about the corona vaccination, IM injection given on the deltoid muscle, which nerve can be injured. In the upper limb, remember, when you're giving IM injection, the axillary nerve was at risk, yes or no? Similarly, we also know that in the lower limb, the IM injection is given in the gluteal region. And if we are not very much aware, then we might damage which nerve? This is sciatic nerve. Because it lies in the gluteal region. You can see the image is the image of the buttock region. So you have to be very sure where to give IM injection. So first of all, let us see where does the sciatic nerve lies. So sciatic nerve, there are 2-3 points over here. Okay. So 2.5 centimeter lateral to the midpoint between PSIS and ischial tuberosity faringe. See, like ASIS we have seen, this is the PSI, this is posterior superior iliac spine. Now see what happens is, if you look at a person from the posterior part of the human body, you will see some sacral dimples over here. There's this dimpling on the skin that is known as sacral dimples. And they are at a level of second sacral vertebrae S2, where the PSIs lie. So you can easily see it and feel it. And this is the ischial tuberosity. Ischial tuberosity is that part. This is the part ischial tuberosity where we normally sit on a hard surface. The part of the bone, this is also a very famous question, is commonly asked in vivas also. The part of the bone of our body, of the hip bone, which actually touches the surface when we sit, touches on the surface when we sit down on any hard surface, is the ischial tuberosity. That can be felt. So we are taking these 2 points, PSIS and tuberosity, and a midpoint of it. This is point number 1, midpoint. Second point is medial to the midpoint between ischial tuberosity, greater trochanter. Second point is this is the greater trochanter. Remember in upper limb we studied acromion over here, no? Likewise, in the lower limb at the level of hip joint, the most laterally projecting bony surface is greater trochanter. It is a part of the femur bone. So again, you take this ischial tuberosity, take the greater trochanter and join the midpoint. And then as you go below, junction of upper two-third, lower third of between the superior angle of pubital or popliteal fossa. So basically it is lying vertically in the posterior thigh region. But it is actually between point number 1 and 2, this region lies where in the gluteal. This part of the sciatic nerve lies in the gluteal region. So if you're giving an IM injection, any your nurses or doctors or medical staff is giving IM injection on the gluteal region, make sure it is not in the path of the sciatic nerve. So what normally we do is, when we start to teach the students how to do IM injection, we divide the buttock, we do make a plus sign, divide the buttock into 4 parts: superomedial, superolateral, inferiomedial, inferiolateral. And it is always said that, okay, it is the superolateral part, this part of the buttock region, where you have to give the IM injection, upper and outer part. So IM injections are given over here. This is the part where the injections are given, whatever intramuscular drugs are given, just to protect the injury to the sciatic nerve. Just to prevent the injury to the sciatic nerve, IM injections are given over here. And later on, you might be, and questions might be coming, you might be encountering the questions that here the IM injection was given to the deltoid muscle. In case of the buttock or the gluteal region, which muscle actually you are giving the injection? It is basically the gluteus medius muscle. Which muscle? Gluteus medius muscle is the one where normally, ideally, IM injection is given to that muscle. Okay, so the sciatic nerve, very, very important. As we move down, common peroneal nerve. Okay, basic anatomy we'll discuss later on, but see what happens is, sciatic nerve is the thickest nerve in the body, thickest nerve. As it reaches at the top of popliteal fossa, it divides into a laterally going common peroneal nerve and a vertically downwards going tibial nerve. This is a sciatic nerve. And this is medial side, that is lateral side. Understand this. This is lateral. Okay. Now, if you look at the bones in the leg, medially we had which bone? We had a tibia. And laterally we had which bone? We had fibula. So this common peroneal nerve, actually, one line only I'm telling you, it winds around the neck of fibula. At the top we have the head, and just below the head we have the neck of fibula. The common peroneal nerve winds around the neck of fibula, as you can see over here. Let me just point out, this is the head of fibula, and this just below it, this is the neck of fibula, and you can see this nerve is winding around. Now, try to feel the upper part of fibula in your own lower limb. The knee region, below the knee, just below the knee on the outer side, feel the fibula. Feel the head of fibula. You can easily feel it. And once you're feeling the head of fibula, you know that, okay, just below this, my common peroneal nerve is going from posterior to anterior. The image that you're seeing is a posterior view. So this nerve is going from posterior to anterior. Now, as you can easily feel the fibula bone over here, and it is lying outside. Now, this, therefore, is the most common nerve to be injured in both upper and lower limb combined. It is the most common nerve injured. I'm writing big injured. Most common nerve injured in combined upper lower limb. Why? Because it is lying outside. It is sort of subcutaneous. So if you are walking, crossing the road, any bike comes and strikes on your outer side, that nerve can be damaged, or a car accident, or you falling on one side, okay, or say there's some fight going on with the hockey stick or any stick and all, and the stick strikes the outer side of the knee, this nerve can be damaged because it is lying between the skin and the bone outside, right? So in many instances, or in the cases also, let me just try to show you. Suppose plaster is applied over here, okay, a below knee plaster. Suppose there is injury to the any foot bones, or okay, any ankle injury, and the plaster is placed. The edge of the plaster, understand this, the edge of the plaster is lying over here, and if that edge of the plaster is very tight, it might compress this nerve also, common peroneal nerve. These are the common instances I'm telling you. Common peroneal nerve is easily injured, therefore it is the most common nerve injured. Points over here. Now, if you know the importance of this nerve, then you will be interested to know where does it lie exactly. Superior angle of popliteal fossa. So actually popliteal fossa is a diamond shaped space, superior angle, and then on the back of the neck of fibula over here, as I told you, because it is winding going from posterior to anterior, common peroneal nerve. Okay. Now, you will learn later on anatomy that what happens when this common peroneal nerve is damaged and all. That is a different thing. How will you check the symptom, signs, and all? Okay, one over here is Brine's triangle. Remember that also. That is actually used in orthopedics much commonly. But are drawn with the patient supine to detect disturbance. Now, there's a lot of injury to the hip joint. They can be fracture the neck of femur or hip joint dislocations. So to detect disturbance in femoral head and neck anatomy, femoral head and neck anatomy is the femur bone. We are discussing here about the bone that is the femur bone. In the femur bone, we have the head and neck at the upper part. Upper part of the femur bone has a big head and a long neck, and then there's a greater trochanter and lesser trochanter, and the bone goes down. So disturbance in the anatomy of head and neck. Fractures are also common, in particularly in old age. In old age, osteoporosis will occur. People fall down, they slip around in the washrooms where there's water on the floor, they may slip. Therefore, it is always advised that if there are old people living in any house, the washroom should be kept at least dry, or there should be some mat, anti-slippery mat should be placed over there, because it will take just one moment for 80, 90-year-old, 70, 80, 90-year-old person to slip, and these injuries are obviously quite problematic, because you need operations over there, you need a 1 month, 2 month bed rest, and it's a big problem. Okay, so do remember that also. Now, how to take the Brine's triangle? Draw a line from ASIS to greater trochanter, A and C. This is point of ASIS. This is obviously the GT, greater trochanter. Draw horizontal line from ASIS. So they made a horizontal line from ASIS below over here. Draw vertical line. So obviously A and C, and then right angle line from here and there. This is the Brine's triangle. Okay. And if the triangle, if the line meeting is above the neck or the head of femur, then obviously it denotes the injury, right? So these are the cases. Brine's triangle, just remember over here. Applied importance is, once you study the fractures and all, then its importance will come into play. Okay. So this was the applied importance, the lower limb. So just let us just recap the whole thing over here. So start with the femoral artery. Understand the applied part. Palpation is very important. Butcher's injury. Okay. Any problem over here? So femoral artery, please palpate this artery. Okay, please palpate this artery. We have seen how to palpate it. Then popliteal artery, it is a bit difficult, but not that difficult, not impossible, obviously. Just you need to do a deep palpation. You can palpate the popliteal artery. It's a very interesting. Posterior tibial artery. Do palpate it as well. Very easily palpated. Anterior tibial artery. Obviously, this cannot be palpated, but just where it ends comes the dorsalis pedis artery. This can be palpated. Then we have the arterial pulse palpation, where they are showing these 4 arteries. Then the vein. The veins in the lower limb are much more important than the veins in the upper limb, clinically. Okay, so great saphenous vein. Similarly, they are not discussed over here, but there's also a short saphenous vein. Okay, let me give you a brief idea. So we discussed great saphenous vein. You look at the image, it is lying on the medial side of the lower limb. Yes or no? Similarly, there is a small, also known as short saphenous vein, also known as the short saphenous vein. It is lying on the lateral aspect. Where? On the lateral aspect. Okay, on the lateral aspect. So if you see a varicosity on the lateral aspect of the leg, but this does not go up to the top. This will be in up to knee only. Great saphenous vein is going in the entire thigh also, but this reaches up to knee only because it drains into popliteal vein. It is on the lateral side. So if you see varicosity on the outside or in the calf region, it is probably small saphenous vein. And if you see on the medial side going up, it is great saphenous. Okay. Saphenous opening, femoral vein, I told you, femoral tapping, how to take the blood out of it. And great saphenous vein discussed, life-saving thing. In front of medial malleolus, just open that area and just put the IV line. Okay. Then femoral vein, you see saphenous opening, 4 centimeter, remember, nerve. Okay, nerve artery vein, remember, NAV, lateral to medial, sciatica, sciatic nerve, intramuscular injection, very, very important, guys. These are must-know things. So common peroneal nerve, most commonly injured. Person normally will come with foot drop. For example, let me tell you this over here, a bit of applied also. The patients come with a foot drop, meaning by they can't extend the foot. Foot will be lying like this. So when they walk, they will be dragging against the floor. Just by looking at the person entering to your clinic, entering to your OPD from the door, just taking 4 steps, you know, okay, it is a case of foot drop. Then the patient will give history and you look for what happened, what was the reason for it, and then think for the treatment. Okay, then Brian's triangle over here, right? So this was all about the, what do we say, the surface anatomy of the lower limb. Okay, and here we have this slides over here. Just remember, recorded live classes. You can take the screenshot of all of this, and you can use the code also Dr Ankit 20, and these are subscription plans over here. And do see, and I will also advise you to download the app also, Auricle app, beautifully crafted app. Even the latest medical news are updated over there. They are also very important, and other social media handles like you have YouTube, Insta, sorry, yeah, YouTube, Insta, other things over here. Okay, just a second, guys. Okay, we have YouTube, we have Insta, we have Facebook, Telegram, all that, right? That's all on my side. I hope you guys enjoyed. Thank you. Bye bye. Any queries, do reach out to us. More than happy to help you guys. Thank you. Bye bye.